Good afternoon, and thank you for coming today to our regional variation in elective procedures briefing. My name is Sandra Shury, and I'm new with the California Healthcare Foundation. My job is to be the director of our state health policy office here in Sacramento. The foundation is based in Oakland, and we are a nonpartisan independent philanthropy dedicated to improving health and healthcare delivery. Today I have a couple of my colleagues with me, Mary Beth Shannon, who is the director of our Market and Policy Monitor, where our variations work is based. One of her colleagues, Stephanie Teleki, is right behind her. She is our queen of all things transparency. So if you're interested in data transparency, talk with Stephanie. And then two of my colleagues, Danny Sandoval, who works in the Sacramento office here, and then out at the registration table was Michelle Cabrera. I wanted to thank Karen Shore and the folks at the Center for Health Improvement for pulling it all together today. Thank you, Karen. You always do a great job. And then also the Assembly Health Committee for arranging the room. And then a special hello, shout out to Terry Boughton, who used to work with the foundation and is now back in the building. So welcome, Terry. Yay. My job is to ask you to silence your cell phones and to basically provide a nice environment for our speakers, and then also to let you know we are videotaping today, and the entire videotape will be up on the CHCF.org web, as will all the handouts and presentations by the speakers. Those should be up within the next couple of days. We do have phone access today, and the phone is listen only. So those of you in the room are getting the full treatment. Others will have to either watch it on their computer or listen in. In your packet is the agenda, the slides from three of our speakers today that we did get ahead of time, some of the reference materials, and most important, a beautiful blue evaluation form, which we do have people blocking the doors, and you won't be able to leave until you fill that out. So do us a favor and fill that out. It's how we make these briefings more relevant to the Sacramento policy community. The reason we do them is to provide information to help you make better decisions, and we really value any feedback you can give us. So I want to turn the day over to Marianne O'Sullivan, who is an independent consultant and was the facilitator of this project.
Good.
Thank you.
Thank you, Sandra. And welcome to, the foundation is very lucky to have you on board, so good. I'm just going to take a few minutes to say something about the background for this California research, and then to introduce our speakers. So this research project, looking at California geographic variation for elective procedures, was launched by the Campaign for Effective Patient Care and with funding from the California Healthcare Foundation. And when the campaign disbanded during this past year, the foundation very generously stepped forward and adopted the project. And under the leadership of Mary Beth Shannon, finalized the work and released it and created a great interactive web map that you all might want to take a look at. And Lawrence will show us some of the shots from it with his presentation. It's at chcf.org/variation. So thank you very much to Mary Beth and the foundation for picking this project up and getting it to completion. And I also want to thank the Office of Statewide Health Planning and Development, and particularly Jonathan Teague, who I think is here. Are you? What do you look like? Hi, Jonathan. And also Karen Henderson, his colleague, and they work closely with Lawrence Baker on and generously provided all the data for this project. So thank you very much for that. And the project produced a lot of data. And there's one other person I want to thank, who is Frances Tompkins. Frances, you want to say hi? Frances worked tirelessly producing Excel spreadsheets and graphs and tables so that we could understand what the data said better and most importantly, better understand how to communicate it. So thank you, Frances. So I'm going to briefly introduce each of the speakers, and then we'll and you have their full bios in your packet. So, and there's a slight switch in the order as you look at the agenda. Shannon is going to sum things up at the end rather than be earlier on the agenda. So I'll just go over everybody's really quickly, and then we'll hear from our speakers. Lawrence Baker is an economist and the chief of health services research at Stanford. And Dr. Baker led the research and the data analysis for this project. And he's going to talk to us today about his methodology and about the key findings for the project. And then Shannon Brownlee is acting director of the New America Foundation's National Health Policy Program. And she's author of Overtreated: Why Too Much Medicine is Making Us Sicker and Poorer, which was named Best Economics Book of 2007 by New York Times economics correspondent David Leonard. And she was also named in 2009 one of 4 writers who changed the world by the World Federation of Science Journalists. And Shannon offered her sage advice to us throughout this project, and she and her colleagues at the New America Foundation authored the brief and the close-ups that communicate the research, and that are in your packets. And she's going to talk to us today about what the impact of all this is on patients, and also sort of sum up for us after we hear from everybody else. And Dr. Lance Lang is, this year was appointed Clinical Director of the California Quality Collaborative. He also serves as Consulting Medical Director for Health Dialogue. And Dr. Lang chaired the impressive, mostly physician advisory committee that very generously guided this variation work, and they're listed in the brief that you have. And Lance is going to talk to us about what might be driving some of this variation. And then Ben Moulton is Senior Legal Advisor at the Foundation for Informed Medical Decision Making, which is sort of the national hub for shared decision making, I'd say. And prior to joining the foundation, he served for 15 years as the Executive Director of the American Society of Law, Medicine, and Ethics. And Ben will talk to us a bit about the ethical imperatives that are at play here, and also give us some thoughts about how California policymakers might get involved going forward from here. So we'll hear from the speakers now, and after we've heard from all the speakers, then we'll look forward to hearing questions from you all. So I'm going to start with Dr. Baker.
Hi. So let's see. What do I do here? I push. Oh, don't push buttons. All right. Well, it is a pleasure to be here to be able to tell you about the work that we've been doing. This, as Marianne said, is work that has benefited from conversations and collaborations with a number of people, all of whom have made important contributions. Marianne and Francis, Jonathan and Karen at OSHPD, the folks at the foundation, Lance and the advisory committee. So, in some ways, I'll tell you all about all this great work that I did, but it's work that I only was able to do with the support of a lot of people who made really enormous contributions. So, thanks to everyone, and delighted to be here to be able to share the work with you. Now, the problem is we've got like 15 or 20 minutes, and this at one level, this is an easy project. It's got like rates, and around California we show the maps and we're done. At another level, there's a ton of detail that goes on below, and sitting up here, I can't tell which details you want to know. So I made it up. I guessed which ones you want to know, and I'm going to tell you those. And then there will be some chance for a conversation, I think, as we go forward. If there are other pieces that you don't think I talked enough about, there's probably a half an hour's worth or so of detail in the methods. But we'll pick up what I hope are some of the key pieces. Okay, so we started this out thinking that it'd be cool to go find some procedure utilization rates around the state of California. We've seen the Dartmouth Atlas. We've seen lots of things that do variations in procedure rates and treatments in different parts of the U.S., mostly with Medicare data on the over 65 population, and a lot of different ways of slicing that up. But we thought it'd be cool to do that in California specifically. And with a little more precision, we thought it would be fun to think about these kinds of situations where the treatments are sensitive to patient preferences, to patient information, the decisions that patients have. Some medical treatments not that sensitive to patient preferences. There's like one right thing to do and it's going to save your life. It really doesn't matter. You're not going to get asked. They're just going to do it, and that's what we want them to do. But in other cases, treatments have costs and they have benefits, and for any given patient, those may stack up one way or the other, and it really starts to matter what the patient's preferences are. And so we wanted to think about these kinds of conditions that are called preference-sensitive conditions. And within that, a little more specifically, we wanted to start a conversation or try to use the data to look at an area in which people are thinking about shared decision-making, ideas, tools, opportunities to get patients more information so that they can better participate in the decision. So with that sort of a framing, we went looking for some conditions to study, and we went to the data and we started working on it. We came out having done lots of work with some results that use an underlying methodology that I think has a few things that I want to call out particularly. So just here's a little bit of the highlights and then some detail coming. So what are we doing? We are trying to calculate population level rates of use of a range of procedures, I'll tell you what they are in a second, for all of California. So we're going to say things like the rate of using open heart surgery is 50 people per 1,000 people in an area, population level rate of use of a procedure. We wanted to get that for all of California. We want to include hospital procedures, because most of these things are done in the hospital, but we want to be a little broader than that. And so we're actually quite pleased that in this project we can use some ambulatory surgery center data, because some of these things are not always done in hospitals. So we're quite pleased with the fact that we can extend beyond what is commonly done just in hospitals and use some ASC data. We use all payer data here, so we have data on Medicare, Medicaid, private plans, HMOs, PPOs, all the different kinds of payers, which we also think is really an innovation in this project, a really useful piece of the contribution we can make. And then, I guess going along with that, we have patients under age 65. A lot of the variations work, of course, focuses on Medicare folks over the age of 65, so we can do work on the younger population. And as I'll talk about in a few minutes, we do a lot of work on risk adjustment. We're kind of proud of that, so I'm going to spend a couple slides telling you about what we think are cool pieces of the risk adjustment that we do. So that's kind of the highlights. What do we hope that this is a contribution to the overall literature on these questions. We have had for a long time Medicare over 65 specific analyses of a few different procedures, but when you do that, you can't study the range of procedures you want to study necessarily that might be relevant in the under 65 population. You can't study all the payers, and you kind of can't get to the level that we can get to in this project. So we're specific to California in a certain set of procedures, but we hope that this is a real contribution to the overall literature in this area, and we're trying to use this as a way to drive forward thinking on variations. Those are kind of the highlights of what we're doing. So what are our data? So a little bit more detail now. We are using the OSHPD discharge data and the ASC encounter data. We were very pleased to be able to work with the folks at OSHPD to have some analyses done on the non-public versions of the data, so we can take advantage of the richness of this information. So this, of course, has all the people in California who are hospitalized, essentially, lots and lots of the ambulatory surge visits, and so we get a pretty comprehensive look at care in these places in California. We pool together, for purposes of getting enough sample, 2005 through 2009 data. So there's a 5-year data range all dumped in together to make sure we have enough people to do the analyses that we want. And if you're really getting into the weeds a little further, we don't exactly use everybody in the data. We're tending to focus on people age 20 and over. We're tending to focus on people in acute care hospitals, not in all the range of different kinds of hospitals that are in there. Sometimes we make some other exclusions for people, say, based on their residence county. They've got to be resident in California, of course, if we're looking at California. So we're looking at most of the discharges and most of the people, but not all of them, with some exclusions. We go through there and we find some, we look for procedures. So I'll show you a list in a second of all the different procedures. If it's in your packet and you want to skip ahead, you can do that and see what the list is. So we came up with a bunch of things we want to look at, and we made rules like when we see a certain treatment code, an ICD-9 code or a CPT code, then we'll have found that procedure. And then we went scanning through all the claims, all the years, looking for cases where we found those. So we were basically just counting hospitalizations in which something happened, or ASC visits in which a certain thing happened. I'll show you the things in a second. In some cases, we restrict our population a little. We say, well, we only want to look at people who had, say, an open heart surgery if there also were some indications in their diagnosis codes that it might not have been completely obviously indicated. So we do things especially around this notion of elective, which we'll put in quotes, because finding things that are elective in the minds of any given physician may not always be the same as finding it in OSHPD discharge data, where there's some abstraction and things like that. So we tried to do that. We often went through, in a number of cases, looking for people who had evidence in their diagnosis codes that they might not have obviously needed a condition. And we say this is an elective patient, a patient who got open heart surgery electively, someone who didn't, say, have just had a heart attack, where it's pretty clear that there's a good indication for doing something. So I'll tell you a little bit more about that as we go along, but we're looking for events where there are procedure codes, and then we often look through the diagnosis codes to try and find people with particular conditions. Here's the list. So we have 3 heart procedures that we were looking at: coronary angiography, a test for how blocked up the arteries on your heart might be; angioplasty, using a balloon generally to open up a blocked artery; and in the jargon, CABG, coronary artery bypass graft. This is like bypass surgery. So 3 measures. All of these we try to look for more elective cases. So if you just had a heart attack, or if you have something related that suggests that these are probably really useful for you, we don't count you in there. But we're looking for people who didn't have indication that something was seriously going on, who got these anyway. We call that elective. Childbirth procedures, we have 3: cesarean section delivery, induction, and vaginal birth after cesarean delivery, 3 that have gotten a reasonable amount of attention lately. And in a couple of those, again, we go through looking for diagnosis codes that suggest that this was more an elective as opposed to a clearly indicated case. Joint replacement, we look at 2 hip replacements and knee replacements. We looked at hysterectomy and mastectomy, and then carotid endarterectomy, cholecystectomy, removal of the gallbladder, and then weight loss surgery. So a handful of different things representing a fairly wide range of cases where we thought that there was some reason to look at these from a shared decision-making, preference-sensitive kind of standpoint in the development of the project. All right, so then we wanted to get area rates. So we don't want the whole state, we want areas broken down. So we take each patient, we assign them to an area based on where the data says they live. So if you have a residence zip code in the data, and we can link those to 2 different kinds of geography. One is called the hospital referral region. These are kind of big geographic areas around California. There are 22 of them. They were made by folks at Dartmouth when they made the Dartmouth Atlas, and so we get their definitions and we make 22 HRRs. Each HRR, it turns out, is made up of usually several, but sometimes just a couple constituent things, smaller things called hospital service areas, HSAs. So we also did HSAs. There are 209 HSAs around California, so you can imagine these are a little smaller, kind of dotted around. I'll show you a map in a second. You can see some HSAs. So we're doing our work generally here at the HSA level. We're doing this based on patient residence. Worth noting for just a second that these are patient residences, not necessarily hospital locations. So you might live in one area but get your treatment in another area, and that's something that is, it's always a little tension in these kinds of things. Do you do where the patient lives? Do you do where the hospital is? We're doing where the patient lives because that allows us to do population level rates. We spend a lot of time looking at this, and we do find that in quite a few cases, patients are getting care in the same place that they live, but not always, and in some procedures more than others. One of the notable examples of the not so much is cardiac surgery, where it's an open heart surgery where not every hospital does it. So you might live in a hospital service area, but have none of the hospitals there doing it. You may have to go next door to get to a big enough hospital. So in that case, some people move from place to place, and that's just something to keep in mind as you think about the data. We then, kind of go through and create area rates of procedure use per population. Like I said before, it's, how many open heart surgeries per 1,000 population. We're calculating rates like that. We only do it when areas have at least 15 procedures because we don't want to get into revealing anything individual about a person in a small sample. So we're making sure every area that we report has 15 cases. And then we do risk adjustment. I'm going to talk for a couple seconds about this. Risk adjustment tries to adjust statistically for variations across areas in things like age and sex and income and education rates and stuff like that, because we know that different parts of California have different characteristics, and some of the variation in procedure use that you might see might be related to these kinds of variations, and so we want to adjust for that. We do that with risk adjustment. The risk adjustment technique that we use is a standard regression-based risk adjustment technique. You see this in lots of different papers. We're doing essentially what everybody does. And we put in a bunch of controls that are the things that we ultimately risk adjust for. And we go a little beyond in this, in our risk adjustment, what is done in some of the other papers that are out there. So we are pleased that we're able to risk adjust, we think, a little more finely than is sometimes done. What are we controlling for? Age of the population, sex, the share of the population's men and women, the race and ethnicity of the population share that's Black, Hispanic, Asian in a given area, education rates, income, insurance coverage, Medicare, Medicaid, PPO, HMO, uninsured, different rates in different parts of the state, and then the AMI hospitalization rate and the rate of hospitalizations with diabetes diagnosis, which we think are likely to be measures of health status in a given area. So the idea of the risk adjustment is to say, once we've done it, we should be able to statistically equalize areas on those characteristics so that the variation that you see is not because some place has an older population, is not because they have a wealthier population, is not because they have more insured or less insured people. We're statistically trying to adjust that away, and we can do it across a wide range of different characteristics. Now, I'll just make one other comment, sometimes people have said to us, well, you know, it's not the diabetes rate exactly, it's the obesity rate that's the kind of thing that you should be worried about, or it's not what you have up there on that list, it's the smoking rate, or it's the language that people speak, or it's immigration status. And the standard answer to that, and it's, I think, it's the right answer statistically, is that as long as we have things in that model that are correlated with those things, as long as I have something in there that's correlated with the obesity rate, the diabetes diagnosis rate, which is closely correlated, I'm going to be able to capture quite a range of different kinds of things that might be going on. The risk adjustment will capture things that are correlated with what's in the model, as well as what's exactly in the model. So we think we go a long ways in this kind of risk adjustment to statistically equalizing variations across areas. I'm going to run out of time in a second, so I don't know if it's worth going through this. This is a little example and a sense for how important, or actually not so important, risk adjustment turned out to be in this data. So, yeah, it's a little small, isn't it? So up on the top, yeah, so can't you read all? Up on the top, you see a distribution. This is for angiography. Yes, for angiography. So taking the measure of blood flow around the heart for a patient who's got some heart problems, you want to go measure that. So you see a distribution from left to right of the different rates in 209 areas in California, and you can see they go from 100 to 200, and up on the high end, on the top up there, up near 3,000. There's an area that's way the heck up there. So there's the little bit of the distribution you see across areas. That's just in the regular rate. Now, some of that variation is due to the fact that some of these places are older or richer or less or more educated or have different insurance rates, and we want to adjust that out. So we run the risk adjustment. In the bottom part is the variation that you see after I do the risk adjustment. Now, it's I don't know, can you squint and see this? If I squint correctly, it takes actually years of training. You have to squint correctly, and then you can see that the wide part, the tall part of the distribution is actually shrunk a little bit together. It's not very much, and I'm going to talk to you about that in a second, but it shrinks a little bit together. That says some of the variation in the top is due to some of these things that we adjust out, and when we get rid of them in the bottom, there's a little teeny bit less variation. You also notice that the 3,000 up there comes down a bit, because some of that appears to be due to some of the things that we're measuring in the variation, in the risk adjustment, right? So you see the distribution shrink a little. What's left in the bottom?
So he's pointing out that spot moves over here, I think.
That's, yeah, it's one of those two.
So there was really out there, and now it's just out there.
Just way out there. Yeah, exactly. Those are technical statistical terms he's studied for a long time to get those. But yeah, so that's actually what's kind of happening in the risk adjustment. There's one way to think about the width of a distribution, the spread of a distribution. That's the standard deviation measure. So you can see up on top there it's 281. After we do the risk adjustment, it's 255. It comes down a little bit. A little bit of the variation that you see in unadjusted numbers in California is always due to these characteristics that we risk adjust for. But once you risk adjust for them and you're statistically equalizing across areas, there is tons of variation that is left over. That's kind of the story of this. And this goes for all the measures that we look at. We made lots of attempts to get this variation to go away with measures, with things that we can measure with statistical techniques. It does not go away. It is not due to things that we can measure: age, sex, race, education, income, measures of AMI rates, uninsured rates. It's what's left over after we've gotten rid of that, and it's still pretty big. So that's sort of the underlying piece of the story. That's what I wanted to emphasize about the risk adjustment. Okay, now a little bit about what we got. Oh, yeah, you know, we calculate things as relative to the state average a lot. So we're going to see things like 200%, which is going to mean twice the state average, 50%, half the state average. And we did spend a lot of time doing like confidence intervals and tests for statistical significance. If you want to look that up, it's on the web. I'm not going to show you a lot about that here. The stuff we're showing you is statistically significant differences. Okay, so the folks at the California Healthcare Foundation made a totally cool website where you can go and you can see the variation. You could go, I don't know if you have your laptop on you. If you were my students at Stanford, you would all have your laptops open and you would be going to check this out. You can go check it out, chcf.org. Oh, this is publications, but you can go down variations. /variations will work. This is like the long way to get there. If you go /variations, you can see this. The map is interactive. You can click on places, you can move it around, you can change the view, like you can do all kinds of cool stuff. Definitely go and check it out because it's like, I mean, I make these tables and type them out, but this is like very nice color, all this kind of stuff. So here's a handful of screenshots that we pulled off the web that illustrate a little bit about what's going on. And highlight number one of the results is there's a lot of variation in California, even after we risk adjust in these populations. So that point will come through in just a couple of these slides. Here is for angiography, checking blood flow around your heart. The light areas down here, up here, these are places that are not doing as much. These are the least prevalent places. So they're half or less of the state rate. The red places are more than 300% of the state rate, so more than 3 times the state rate. So you see areas go from half the state rate to more than 3 times the state rate. The big users of these are in the Central Valley here, Fresno, Bakersfield, this kind of range, and then Clear Lake up here. This is Clear Lake, St. Helena Hospital and other places up there that are doing tons of these things, and they're doing a lot more than other places. Clear Lake has a rate of more than 5 times the state average in terms of their use of this particular procedure. And so one of the top line stories here is just the amount of variation that exists after you've adjusted for the things that we've adjusted for in the ways that physicians practice, in the ways that hospitals operate, in the ways that the healthcare system ends up getting care delivered to patients in different places. There's some clustering. So this is coronary angiography. This is the test that you do that might lead you to do other things like give a patient angioplasty, give a patient an open heart surgery. And so lo and behold, if I do the map for angioplasty, I get kind of the same story. Clear Lake here, very high, more than 5 times the state average, but a pretty healthy cluster of places doing quite a bit in the Central Valley, same places doing the angiograms are doing these kinds of procedures. And you see some places that are still quite low, doing much less than the state average, and they tend to be correlated too. So in some of these, there's clusters. Places that do a lot of heart stuff in one area tend to do it in other areas, and so you see patterns that work out that way. Here is for coronary artery bypass graft, bypass surgery, and it follows statistically a lot of the same patterns. It gets lost a little because the amount of variation here is a little less than it is in some of the two that I just showed you. But still, Clear Lake's kind of popping up. Some of these places are a little on the high side, but not a ton. And then Fortuna actually shows up as kind of an interesting one there. That's a little out of the blue. So there's some patterns that cluster, and sometimes they get a little bit. In other cases, the patterns are different. Here we move to a delivery-based or childbirth-oriented kind of procedure. This is vaginal birth after cesarean. This is one where we're maybe worried a little bit that we're not using enough of this, that the knee-jerk reaction of the medical profession is to do a cesarean delivery on anyone who shows up who's had a previous cesarean. And there may be opportunities to not do that, which might be good for folks. And so there's different patterns of care, different people involved, different populations. And here you get a different pattern of variations, but you still get lots of variations. Right? So the higher utilizers tend to be around the Bay Area and way up north, really low out in some of these areas. Purple are places we just didn't have enough cases to do the analysis. So this is one that's a little more sparse. But you see a lot of variation here too, just different patterns, suggesting different people and different populations involved.
It's fair to say that where there's insufficient data, this procedure probably isn't offered.
Yeah, actually, that's a really good point, because we only counted places when we had at least 15 times seeing the procedure. So if you never, ever do it, you won't have 15 times seeing the procedure, a very low rate that'll just look like no data in our analysis. So you might, statistically, I'd have to check a little to make sure I wanted to make a strong statement in that direction, but it seems pretty likely that that would be the explanation for some of these places. If they just never do it, it's going to be purple. So we'll just skip past knee replacement variations again, and we'll skip past this one. Yeah, so I'll tell you what I'm doing here in case you want to look it up in your packet. This just takes all of the different procedures we looked at, tries to give you some sense of the amount of variation, the high to low in the state. So I just showed you a few on the map. You could have sort of figured out from the map what the variation high to low was. This tries to summarize it and gives you the ratio from the 90th percentile area to the 10th, kind of the top part of the distribution to the bottom. What's the ratio? And the answer, and sort of the takeaway point is they're all pretty big. 1.6 is about the lowest. I'll mention this one in a second, hospitalization with hip fracture. Cesarean delivery is about the lowest, but we're up to 5. Where's the 5? 5 on VBACs, 2 or 3 on PCI. So there's some pretty sizable variation in pretty much all these conditions. The one thing that I put on the bottom here, hospitalization with hip fracture, this is a typical check where people think this should always be the lowest. This is one where there should be less variation, so we did it as a check in the way that lots of other studies do, and in fact we find that it fits our pattern. This is the lowest variation in our study too. So that's kind of a validity check. One or two quick things to mention. One of the things that's been going on in this literature for a while is a lot of attention to over 65 populations in Medicare, leaving the question, if I see an area that's really high in Medicare, do I know that that area is really high in the under 65 population too, or is a lot of different stuff happening that's going to confuse me, make me unsure what to do with the overall policy conclusion? So we were able to do some looking at that here, and I'll just tell you the kind of the basic story. These are the plots for two conditions, or two treatments: angiography, cholecystectomy, that's gallbladder removal. Here we have the rate for the under 65 population on the x-axis, and on the y-axis we have the rate in the areas for the over 65 population. We split them in two, we calculate a rate separately for each age group, and then we plot the points to see how they line up, and the answer is they line up here for angiography quite well. The statistical correlation coefficient is 0.96, the highest you can get is 1, that's really close to 1, so that's quite good. Not always do they line up exactly perfectly, but almost always they line up okay. So here's one where it's kind of okay. They're, you know, as you get higher on the under 65, you're probably getting higher on the over 65, but not every time. Correlation coefficient here is about 0.75. It's a little bit lower. So one of the takeaways from this, and one of the things that we're interested in thinking about further, because we think it adds to the literature, is the fact that there is generally a pretty good correlation between the over and under 65. Not in every case, not always as strong from one measure as it is in one measure as it is in another, but there's a lot going on that correlates across these measures. So we see significant variations. We see a little more in some procedures than others, but in pretty much everything we looked at, there was a lot of variation. And the over and under 65 rates are often correlated. I'm going to run out of time, so I'll just ask you the question, because you maybe can tell me the answer. Which rate is right? You know, we got variation in the rates, but one of the really interesting questions that's floating around, and the folks that are going to talk after me can talk about this too. One of the really interesting questions is, you know, is the highest rate in California the right one? Should we take everybody and make them look like Clear Lake? Or do we actually want to get people, the high people down? And we need ways to start to figure that out. We're worried in a lot of cases, because there's a lot of evidence out there that we overutilize some of these procedures, that the high-end users are probably headed in that direction. We can't prove that in this study, but you might rationally worry that that's going on based on the literature that's floating around out there. But not in every case are we always worried about overutilization. I think in vaginal birth after cesarean, we're worried about underutilization. And so, same story. The literature would suggest that some of the places that are using it very little should probably be doing it more. We can't prove that in this study, but we hope it gets a good conversation going about how we should think about that. And I guess the other folks on the panel can talk about this better than I can. There's a lot that could be done. We are not doing enough in our healthcare system to address, to understand these kinds of variations. We're not doing enough to get patients involved in their decision making, to think about these kinds of procedures. We're not doing enough, I think, to incorporate that throughout the payment structure and the training of physicians in lots of different ways. I think we should be doing that. Hopefully this kind of data will get us started on, but I'll let people who know more about that talk about these kinds of things. Thanks.
If you give
Oh yeah, you want the clicker. Yeah.
It's a real pleasure to be here and to have been able to participate and advise on this study, which I think is a really important study. The fact that we see the similar variation under 65 that we saw in over 65, that we see it when we look at all payer data, when we bring in you know, a whole mix of payers is really important. We've been assuming that, but to really document it is a big deal. I think I've talked to a couple reporters who knew about this in advance, and the first question I asked is about what I think about some of the high and the low areas. And I think I want to emphasize what Dr. Baker just said, which is this is statistical analysis. It's not normative. We don't know the right rate. So we've made comparisons to the state average. And we've seen a lot more where there are multiples on the high end than we've seen where there was less than half on the low end. So we really didn't find very many areas where there was really low utilization compared to the state average. So that's, I think that's just the way the data passed out. We don't know the right rates. But what we do know is that for docs in practice, it's really important to understand how I, as a physician, compare to my colleagues so that we can think about it. And I think that's one of the most important things about this study. And what I hope any docs and providers, hospitals take from this is an opportunity for some self-examination. Most of us, if it's a hospital, we build the hospital and we provide care and we do everything we can to do a good job. And if we're a doc, we get through with training and we put out our shingle and patients come see us. And there are some organizations of care that provide feedback, but I think one of the things that you see in the data is that it's more isolated areas that are really high, and there's less organization of care in those areas, and you'd probably guess that those hospitals and those doctors haven't seen how they compare to anyone else before. And so I'm hoping that this study serves that purpose of self-inquiry, and we're actually inviting the communities to join the providers in that inquiry as to, let's figure this out. So I think that's really the first thing. So in explaining variation, one of the first issues is the doc and the hospital practicing in isolation where they don't know how they compare. The second is the business model. This gets more controversial, but there's innumerable studies that say that fee-for-service, where you pay for volume, gets volume. And one of the things that the health reform bill tried to do was to change that so that there's a shift to pay for value or quality. And I mean, right now in a hospital, if I practice there, I actually get paid more if there are complications than if there aren't. And so again, if you look at geographic variation, the places with the highest rates tend to be predominantly fee-for-service. But that may also hide some variation because of the blending of all payer data. In the large urban areas, we have a whole mix of business models. And we don't know what the rates are by business model within LA or Orange County or the Bay Area or Sacramento, because those are areas where there's a whole blend of different kinds of business models. So one of the things we might do going on is to try to get some denominators. We don't have a comparator. We can't calculate a rate without knowing how many people are in each of the business models in those areas. But so we only are doing population rates. But where you get isolated areas of fee-for-service, we know that there's more care being delivered on these kinds of procedures than there is where there's a blend of business models. So this tends to reinforce that where you have fee-for-service and you pay for volume, you get volume. The second has to do, and this is where we really want to focus time, because there's a big deal about how patients and doctors make decisions together. And there's a lot of literature about how patients might make different decisions with their doctors if they really understand their choices. And in fact, I'll present some of that data. In order to make a good decision, the first thing is that patients have to, this is more about how often is there big decisions. And in fact, it's not just big procedures like we're looking at in this study, but whether or not to take a medicine, whether or not to get a test, because once you get even if it's a very inexpensive little test, like the test for screening for the possibility of prostate cancer, if you get it, if it's positive, it starts a whole cascade of things. So deciding whether or not to get that test is a really big deal. these are some of the numbers about how often those kinds of questions come up, and it's actually really common. 82% of adults over age 40 have made one of these kinds of decisions in the last couple of years. And when they make those decisions, I should give a caveat here. I'm trying to summarize really big studies in a very short amount of time, and any one of these things could take a whole hour. So I'm going to just kind of gloss over the basic concepts. In order to make a good decision, the first thing the patient needs to understand is the evidence about the potential benefits and harms of all their alternatives. And one of the things that has been documented is that when you ask patients as they're making these decisions some key knowledge questions, they may, if you first ask them, do you know what your choices are and do you feel comfortable about that? Generally they say yes, but then you ask them some detailed questions and they can't answer them. In fact, little more than random. If you ask 5 questions, generally 1 out of 5 is correct, which is, that's what you'd expect if they just checked randomly. I've tried to, for those of you who are interested, I provided the reference for that. And I wanted to give one example because I think it really outlines it, there's one of the things I want to point out is that doctors and patients may have different values, but there's also times when the quality industry, of which I'm part, I've spent most of my career doing quality improvement, is that we try to go from science to what we think is the right thing to do. And the NIH, the National Institutes of Health, concluded at a big conference in DC in 1990 that because for breast cancer, a lumpectomy with radiation had similar mortality to full mastectomy, that the right thing to do was lumpectomy. And the rationale for that was about survival. And if the survival's the same and you could keep your breast one way and lose it the other way, well, geez, there's a right answer here. Well, it turns out there's more parameters that might be important to patients than that. So yes, survival's the same. There's big difference in cosmetics, but there's a slightly higher recurrence rate, even if it doesn't relate to mortality, if you do only a lumpectomy. And treatment's different. You need radiation if you have a lumpectomy. And that's got consequences and harms, and it doesn't feel good. And if you have a recurrence, there's a chance of having more surgery. And so it turns out that, in fact, providers and NIH who looked at that just you keep your breast or you lose your breast and mortality is the same, and came to one conclusion, but women had a lot more values that they brought to the table. And there were a lot, just to summarize it, who really wanted to be done with it and who didn't want to have to worry that there might be a recurrence, even if it didn't affect how long they lived. And so it's turned out that about 1/3 of women, when they really understand their choice, prefer to have a mastectomy. And it's a very legitimate decision, and that we in the quality industry shouldn't be making that decision for people. It should be a shared decision. So what happens when there's shared decisions? And what happens when there's enough information exchange that patients can actually answer all 5 questions, and where you then go the next step and figure out what the values are, the preferences, the priorities in life that different people have? Well, the most important statistic up there is that 40% of people, 40% fewer people are passive in the decision. And so they actively participate with their doctor. They own the decision. And then for those who care about healthcare policy and and are we spending money we shouldn't? Then there's other statistics that are important. On the preference-sensitive procedures that we profiled in this study, about 25% of people for whom the procedure might be appropriate, they would, in a health plan, they would pass prior authorization, but they would still choose because they now understand their choices not to have it. And that's really important. So it's not about rationing. And actually, you get a bigger change from actually getting patients to participate than you do in the 1-800-MOTHER-MAY-I approach. That actually 25% of people choose not to have these big procedures. You get a 30% reduction in use of postmenopausal hormones. You get a 20% reduction in a decision to test for prostate cancer. Many men, when they go to the doctor for a physical, the prostate cancer exam, the blood test is just routine. The patient doesn't make a choice. It's part of a whole battery of things. But 20% would choose not to get it. And 14% actually increase their use of colon cancer screening, for which there's really good treatments. So I think, in summary, we're saying to all providers across the state and all communities across the state, please look at this data and use it constructively to think through why you might differ from the state average and figure out, do you feel good about that difference? Second, we're really calling on patients to work with their doctors in a much more active fashion. And I think third, from a public policy perspective, we really need to look at and support the kinds of things in the health reform where we can move away from paying for volume toward paying for value, for quality, and for the time it takes to do shared decision making, which now, if you're only paying for volume, the doctors don't have time to do. So thank you for your time.
Thank you, Dr. Lang. And now we'll hear from Ben Moulton.
Right. I want to thank the California Healthcare Foundation for inviting me. I've traveled all the way from Boston. Hopefully I can say something profound and insightful. However, I will suggest to you that having watched the Red Sox play on ESPN all the way across country, having landed with a 3-2 up and Tampa Bay losing by 7-0, and then getting to the hotel and finding that they had lost and Tampa Bay had won, profound thoughts may escape me, but I'll try to, and dark thoughts enter my mind. Let me just share with you my background. I was a trial lawyer, did malpractice defense, and I've also done malpractice plaintiff's work. Got an MPH degree at the Harvard School of Public Health. Have thought a lot about issues around patient care, and I believe profoundly that patients, autonomous patients, have the right to information, so they make decisions that align with their values and their preferences. And I think shared decision-making is a solution that we should all embrace. It's not a Republican or Democratic issue. It's really a red, white, and blue issue. It's not a rationing issue. I mean, I think we all should move in the direction of having access to information so when we make a clinical decision, it aligns with our individual preferences and values. So that's my bias. So what is shared decision-making? It's a process of interacting with patients who wish to be involved in arriving at an informed, values-based choice among two or medically reasonable alternatives. There's a term for this, and we're really talking about preference-sensitive care, and that you could probably come up with a list of about 15 to 20 conditions that really encompass preference-sensitive care. Jack Wenberg at Dartmouth says it really accounts for 25% to 30% of all care rendered in the United States. And if you look on the left, this really looks like informed consent. You know, if you're an attorney, right? We're going to discuss risk, benefits, severity, alternatives, et cetera. But what's special about shared decision-making with the use of good decision aids is the ability to really tease out value-based preferences and have that dialogue between the clinician and the patient, so what is selected ends up being actually what the patient wants and desires. So another way to think of it is we're going to stop making decisions in the face of avoidable ignorance, right? There's a way to deliver the information. So we have evidence of the problem. I'm going to say to you, we have over 40 years of research at Dartmouth indicating that there is a huge variation issue. We also, Lance has alluded to the decisions study, which says that we make decisions consistently in the face of avoidable ignorance. And so patients making decisions in the face of avoidable ignorance combined with clinicians not being able to be mind readers leads to poor decision quality. Lance actually referred to this, which is how well do providers predict patient preferences. This comes from work by Karen Sapuka, the top 3 issues. You can see there's a huge disconnect between what patients value and what providers value in terms of breast cancer. You can see that keeping the breast for providers was a very high value. For women, not necessarily so, only 7%. Living as long as possible was the #1 issue for clinicians, but not necessarily so for patients. The quality of life had a lot to do with it. And then this little outlier, which is, I think, interesting, is no provider predicted that women would consider prosthesis to be a hassle, and that's a significant value. Another way to reframe the issue, and I don't want to pick on Rhode Island simply because I'm from Boston and we do it all the time, but here's a way to think of the issue and the problem. I picked this right off the internet. There's one hospital in Rhode Island that apparently about 5 times in the last couple of years has performed wrong site surgery or operated on the wrong limb. Now, that's a stunner. If you're the head of that system, you're thinking about stop everything, let's figure out what's going wrong, how can this be? I'm going to suggest to you that every day we're making decisions or we're conducting surgery on the wrong patient. In other words, had the patient been fully informed, they would have elected something differently. And so to my way of thinking, that's a significant patient safety issue. And that, how do we go about describing for patients operating on the wrong patient who would say no if they had all the information? And I think shared decision-making is a solution. I also believe that looking at sort of the legal process of informed consent, it's badly broken. It's been relegated to kind of putting information on a form. Even in the Harvard system, people are being chased down the hallway, being asked to sign a piece of paper, often heavily medicated, about ready to have that procedure. And this is a study I just wanted to share with you, and there are more. We could spend a whole day talking about this issue. But it deals with PCI, looking at Yale New Haven from 97 to 98. And this is what the patients believed. 75% believed PCI would help prevent a heart attack. 71% believed PCI would help them live longer. Less than half could name even one possible complication. And 85% were consented just before the procedure by a fellow or a nurse practitioner. From the latest meta-analysis, 61 trials, about 25,000 patients, we know that sequential innovations in catheter-based treatment for non-acute coronary artery disease showed no evidence of an effect on death or heart attack when compared to medical therapy. Big disconnect between the information a patient should know and what they have. So about 2007, I wrote a law review article with Jamie Staples King, who is at UC Hastings, a young, talented JD, PhD. And we looked at all the states across the country, and you can have access to this article. I'm sure it'll put you to sleep. There are about 400 endnotes. But what it says, essentially, is can we do a better job in the way we construct legal informed consent? Can we make it, especially for preference-sensitive conditions, available to all patients? And we argue that shared decision-making, in fact, can be that answer. And if you look at the United States, we have almost an even divide between what we call patient-centered states and physician-centered states. I come from Massachusetts. It's a patient standard, which means you give the information that an objective patient would want to know under like or similar circumstances. In physician-centered states, you give the information that the average qualified physician would give under like or similar circumstances. We know from Wenberg's work and plenty of other people who have been doing research that there is no, quote, objective patient, that patients value information differently. They value risks differently. And shared decision-making allows you to tailor that. And we also know that physicians don't practice in a standard way. There is no standard uniform way. So when you look at the California Atlas that's just been done, variation kind of looms at you fairly large. We also know from the Cochrane Review that doing shared decision-making is a way to impart greater knowledge, more accurate risk perceptions, greater comfort with the decisions, greater participation in decision-making by the patient, fewer people remaining undecided, fewer patients choosing major surgery, and that, I think, will have policymakers intrigued. So to summarize what I believe are the reasons why shared decision-making should be adopted on a large scale is first and foremost the ethical imperative. We've got lots of data going back decades suggesting patients aren't truly informed. I believe it increases the alignment of the individual's preferences and values with clinical decisions, or what I call perfected informed consent. There's no reason why we can't do it. There's also emerging data, some of it right here in California, that it's a way to bridge health disparities. Dominic Frosch down at Palo Alto, Carol Mangione at UCLA, they've all been doing shared decision-making as a way to bridge health disparities, a way to impart knowledge to disadvantaged populations. Mark Ekman, University of Cincinnati, actually has done some work suggesting it's a way to actually change behavior. Interesting, promising research. And lastly is the conservative utilization of surgical interventions and the use of or utilization of medical procedures. So I'd like to think that maybe we can evolve to a world in which we value the quality of the decision made, and that where we impart information and knowledge and we activate the patient. I feel passionately about that. And I think the paradigm is, did the patient know a decision was being made? Did the patient know the pros and cons of the treatment options? Did the provider elicit the patient's preferences? Was the patient asked? That's what I call involvement. Values concordance. Did the decision reflect the patient's goals and concerns, and were they honored? And then lastly, knowledge. Did the patient know what he or she needed to know? And I think if we can move in the world or the direction of that kind of clinical interaction, it's better for the provider, it is certainly better for the patient. And I would hope that policymakers would actually spend some time studying this study, because I think it's really quite remarkable. Thanks.
Thank you, Ben. And now Shannon, please.
I'd like to thank the Healthcare Foundation, California Healthcare Foundation, for making this possible, and also for the terrific work that everybody put into this, this study and the report. And what I want to do is kind of recap and maybe bring some of this home to talk about what the implications are for patients and of this study and the implications for public policy. So why is this study so important? Certainly the over 65, under 65 piece of it is very important from contributing to the literature, in part because there's been an argument about other variation studies that have looked at the Medicare population that's just not true for the under 65 population. Well, we can say now that at least for these 13 procedures in this state, the over 65 and the under 65, pretty much the same stuff is happening to them. The other thing that leaps out about this study is just the sheer amount of variation, a 10-fold variation in heart procedures, 10-fold variation in elective induction. And if you look at what the American College of Obstetrics and Gynecology says about elective induction, it's basically don't do it. 5-fold variation in rates of hysterectomy. Anybody here from Oroville? Tell your mom to keep her pants on. That's the high spot. And in fact, our Dartmouth Atlas, we just did a Dartmouth Atlas earlier this year that found that San Luis Obispo is the nation's leading spot for prostatectomy, surgical removal of the prostate, and probably the world leader. So gentlemen, keep your pants on in San Luis. So
Another piece of it that's really important is that the variation cannot be accounted for by variation in the population and population characteristics. This is really important. So when somebody says, we're doing lots of X, we're doing lots of hysterectomies because our patients are poorer, sicker, blacker, whiter, older, younger, whatever, what this study is showing is that the variation is still very high, even after you account for those kinds of differences in populations. Something else is driving it. And the something else that we think is going on is that physicians themselves differ in their practice patterns and in their opinions about what's right for their patients. Patients tend to think that medicine is very scientifically based. Another terrific survey that was done by by Marianne's organization, CEPC, found that a majority of California voters thought that medicine was scientific and that what their doctor was recommending was based on really valid science. Well, a lot of times that's just not true. And even when the science is there, the recommendation is not necessarily based on the best science. So this is an important piece of this to take-home message from this study. We also know from numerous studies that patients often don't know what they're getting into. And this is really important to think about. Patients don't always know what their choices are when they have a particular condition. When you have early stage breast cancer, you probably do know that your choices are mastectomy versus lumpectomy. But women may not be told all of the pros and cons of each of their choices. And we know that's true from a number of sources. We know it from the decisions trial that Dr. Lang talked about, where there are differences in what physicians think is important and what patients think is important, where patients didn't know the most basic things about the procedures that they had undergone. Really crucial that patients understand. That's the basis of, that's the foundation of informed consent. And when you're giving consent to have something done, when you're not really fully informed, it's not informed consent. And this is a bedrock of what we think of as patient autonomy. And we know this from randomized controlled trials. I'm not sure if Dr. Lang talked about them, but, or both of you, both Ben and Dr. Lang talked about them. But these randomized controlled trials where patients were given something called a patient decision aid that really laid out what their choices were. When you compare patients who have access to those aids and that information versus patients who get usual care, who were informed by their provider, the patients who got information often made different choices from the ones who were informed in the usual way. That's really important. The patients make different choices when they really are informed. And I want to give you an example. I'm sort of struggling which patient example to talk about, but I think what I'll do is build on the example of breast cancer. This comes from a breast reconstructive surgeon at Dartmouth, Dale Collins Vidal. And at Dartmouth Hitchcock Medical Center, they have a shared decision-making program in place. So every woman who comes in with early-stage breast cancer is given an opportunity to look at a patient decision aid, to go through what her options are, and to really consider her own values. And then she does something else. She fills out a little questionnaire that says what her values were. And it turns out that women who value their breasts very, very highly, more than they value not having to worry about a recurrence, tend to choose lumpectomy. And women who are much more worried about a recurrence are going to be more likely to choose mastectomy. So this patient comes in to Dr. Vidal, and the patient has marked that she wants a mastectomy, but she has also said that her values are that she values her breasts very highly. And these don't match up. So Dr. Vidal says, I'd like you to go back and look at the decision aid again. So the patient goes back and she comes in a week later and she says, I really want a lumpectomy. And Dr. Vidal said, well, why did you choose a mastectomy the first time around? And the patient says, because that's what I thought my doctor wanted me to do. So this woman was going to make a life-altering decision on the basis of what she thought her doctor wanted her to do. So this is a really good illustration of how important patient values are in this whole equation and how we need to have a very different way of informing patients. So there are a number of policy implications that fall out of this study. One of them is not that we ought to be aiming for the state rate, because we don't know whether or not the state rate is the right rate. It could be that the right rate, now the right rate, according to my definition, and I think for other people's definition around this podium, the right rate is when all patients who are faced with that set of choices are given an opportunity to really understand what the choices are and make the decision based on their own values and their own preferences, and are able to share the decision with their physician. That's when we know what the right rate is. So the state rate might be the right rate for some things. It might be too high, it might be too low. We really and truly don't know what the right rate is until we start consistently making sure that patients have the ability to understand their choices and to share the decision. So one of the implications is that if you have an area that has a very high rate, you might assume that everybody who wants the procedure is getting it. And that's not necessarily the case. You may be having the wrong patients get it in an area with a high rate. And in an area with a low rate, you might assume that everybody who wants to avoid that procedure is able to avoid it. But in fact, that may not be the case either. So we have to go to the process, which involves looking at these, being able to have access to a patient decision aid, being able to share the decision. So how do we make that happen? There are a number of demonstration projects around the country, and I want to tell you a tiny bit about one of those demonstrations. It's at Group Health of Puget Sound, which is like Kaiser, only up in Seattle. And they have distributed 18,000 patient decision aids to many of their patients. Many patients over 2 years. That's a lot of decision aids. They have the highest patient satisfaction of their entire history. They survey their patients all the time. Their patients are incredibly satisfied by getting these decision aids. They have high provider satisfaction. Their physicians and other providers really appreciate that their patients are really well informed, and they've seen a significant impact in utilization. So what the randomized controlled trials have shown us is there's a real drop in utilization. Patients are less likely to choose expensive invasive options when they really have the information in front of them. Now, that doesn't mean that every patient is going to decide against getting that knee replacement. In fact, some patients, after seeing a decision aid, are going to say, I really do want that hip replacement or knee replacement, while other patients are going to say, I really don't want to get that cardiac stent. So it's crucial that we not assume which direction it's going to go, but the hint is that we're going to see a drop in utilization in a lot of procedures if we had widespread use of patient decision aids and shared decision making. So we need legislation to push for demonstration projects, I think. We need legislation to protect physicians and change informed consent, to strengthen informed consent, to do what Ben calls perfected informed consent. And finally, we need to certify patient decision aids. These aids have to be balanced. If they push patients in one direction or another, they're really marketing tools. So they have to be balanced. They have to really inform patients and help patients understand their own values. And the final piece of this is to think about the kind of cultural impact this really has. What we're really talking about is the democratization of the doctor-patient relationship, giving patients a greater voice. We talk a lot about patient-centered care. This represents truly patient-centered care, and the implications of this kind of study, this regional study that shows variation, suggests that we absolutely need to start thinking about this kind of truly patient-centered care. Thank you.
Thank you, Shannon. Thank you, everybody. That was a great set of presentations. Really appreciate it. So we can take some questions now, if you all have some. Yes. Could you identify yourself too, please?
Joe Parker. I manage the Healthcare Outcomes Center in Washington. My mic's warming up. Hello. So we've talked about possible explanations for the variation, but one thing that hasn't been mentioned, I don't think, is the actual I guess we call the prevalence of physicians or the supply of medical technology geographically. And I'm wondering if that was considered in doing this project, or if there are ways of getting to that data. And I mention that because automatically when I saw Fresno and Bakersfield, I thought Fresno Heart Hospital, Bakersfield Heart Hospital, the two boutique heart hospitals in California.
Let me try to amplify explain what we're talking about here. When I was reading Jack Wenberg's stuff while I was still a real doctor, and a patient would come in with congestive heart failure, and I had kind of a dual role. I was helping manage the hospital at the same time I was still in practice. So I would know how many beds were available for in the hospital, and I would make different decisions by the availability of beds in the hospital. A patient with congestive heart failure, I could manage in my office during the day. We'd put them in the minor operating room, start an IV, give them some medicine. Most often they could go home by the end of the day and perfectly safely be resolved. It's a lot of work, but very safely done. If I had plenty of room in the hospital, that's where they went. And it was very much the same doctor, but based on the resources available to me, I made different decisions. So that's supply-sensitive variation in real life. We did not do this study is all by patient zip code. So we didn't we couldn't get a denominator by facility. So we couldn't do a rate at a hospital. We did a rate for a geography, for the community around those hospitals. And, but definitely there's a relationship even in a situation where it's preference sensitive, where your values might determine the decision. The supply also influences the decision, and that's part of the equation.
Yeah, I'll comment a little bit on just a couple technical aspects. That's exactly right. There's all kinds of evidence in the literature that says that performance of procedures responds to capacity, and it's not always pure chasing money or whatever. It's just like the adaptation of people to the surroundings and the situation in which they work. You learn to use a lot of hospital beds if you got a lot of hospital beds to use, and you learn to use less if you don't. To what extent is that a factor in this data? The answer is it would explain a little bit of this, sort of not in the official data, but it doesn't make it go away. And so just to your example, the Central Valley does have a couple of these heart hospitals. Clear Lake, the highest in the state, doesn't have one. And they don't have a particularly large number of cardiologists either, or cardiac surgeons. They just do a lot of these procedures. And so to some extent it does fit some of the patterns that you're talking about, but that would not make it go away. Like that would not explain all the map that you see here. And the other thing that I just noticed is the subtlety of the kind of question. So if you have an area where doctors are into it, they love doing these procedures and they've grown up doing them, those are the places that put in the heart hospitals, right? It's the question of what drives what is really subtle to start to tease apart. Places where there's a couple doctors who are really aggressive, they may attract more other folks in the end to come work with them. And so, it becomes kind of a trick figuring out which thing was the starter. But to end, I'll just, resonate with the point. Supply is often related, capacity is often related, and that's one of the things we'd want to look at. It wouldn't be the answer to the variation that we see in every case in here. It might be some of it.
Just one last thing. The one set of preference-sensitive procedures that really does track supply is heart procedures. It tracks cath labs. So where you have more cath labs, you get more catheterizations. You get more angiography, you get more PCI. But when you look at Los Angeles, for example, it's got a very high number of orthopedic surgeons, but its rate of knee and hip replacement is not that high. And what's really may be really going on there is that orthopedists, for example, specialize. Some do hands, some do hips, some do elbows, some do knees. And so you really have to get much more fine-grained to see the relationship between supply and the procedures. But opinion is pretty powerful.
So you could have a place with the same number per capita of the particular kind of proceduralist, like an orthopedic surgeon who does knees, and one physician is much more likely to recommend surgery than another is. So the answer is it's complicated.
Yeah, Marge.
Hi, Mark Horton, recently with the California Department of Public Health. Just a couple of comments and ask for response. First of all, I appreciate that the study overall showed that there was relatively little, a smaller amount of the variation was due to various demographic characteristics. However, I think over and over again, statistics have shown that in fact there are statistical differences between the number of procedures that are done based on race, based on the kind of insurance a person has. So I wouldn't want the folks in this audience to leave this room thinking that while on the one hand, cumulatively it doesn't necessarily represent a majority of the variation from from place to place. There still are significant and unacceptable, differences between elective procedures, between race and then secondly, as much as I appreciate the attention by the second two presenters about the issue of communication and doctor-patient communication and decision making, I don't think we have good statistical evidence that in fact that represents a significant, once again, variation in why rates are varying from in other words, to what extent is this a solution, to what extent that kind of communication is contributing to these variations is not known. And I think there's a lot more work that needs to be done to tease out those factors.
So, two things. Would you respond, Lawrence, to the first comment about disparities?
Sure. You're right. That's exactly right. So in our data across areas, the application of risk adjustment for age and sex and race and the things that you talked about that you saw up here does not make a huge difference. But in the models across areas, those things are related to healthcare patterns. And maybe more importantly, one of the things that statistically is going on underneath this is we're looking at 209 areas in California. So we are aggregating populations together. And one of the things that happens when you take and aggregate these areas together and then you start to compare, say, the age distribution or the race distribution across these areas, is that it gets smoothed out a little bit, right? One area is not that different than another area, and surprisingly so, the areas in California have a lot of similarities. There are some that, the Bay Area pops out relative to the Central Valley and things like that. I mean, there are differences, but they get compressed when you aggregate to the areas, and so the differences in the aggregate are not as big as you sort of think about it at an individual level, so they don't explain as much in these area levels. If you take individual patients and you make comparisons within these areas, you will get back to what you're talking about, which is we do see more of the variations at the smaller individual neighborhood person level kinds of things. That's not what we're doing here. We're doing something bigger than that, and so it's an important point, and I think you're right.
Thank you.
I think there's another piece of the puzzle here. The point is not to get rid of the variation. The point is to make sure that patients are getting the care that they both need and want. And so obviously one of the things that keeps you from getting care that you need is having adequate access to the health system, to having insurance. And it seems to me that one of the ways that we want to make sure that patients get what they need is to make sure that we can A, pay for it, and B, that they really want it, that it's personally the right particular procedure for them. So I guess squabbling over what the cause of the variation is may not be as important, not squabbling, but disputing the variation may not be as important as sort of recognizing the fact that patients really are not as engaged in these decisions as I would think we would all want ourselves and our families to be. And that's what I hope the take home is from that piece of it.
So where there's this level of variation, it points to the fact that clinicians are not of one mind about how to deal with these particular sets of conditions. And so maybe more than in other places, we really ought to be making sure patients are informed and taking part in the decision, because there's going to be so much variation. But the idea is not that shared decision-making would flatten out the variation. Marge?
Well, it would. I think I'd just like to respond to the last piece that you said, that we didn't measure how much shared decision-making there is by geography. So
Actually, we kind of know, not much.
well, we'd have the reverse. We know that when there's more shared decision-making, overall, these kinds of procedures are reduced by about 25%. The way I got into this was that one of the early studies that's in the Cochrane collaborative aggregation was done, that touched on my practice, and some of my patients were in it. And I was at Group Health in Seattle. And our initial rate was about the 25th percentile nationally. And just by providing decision aids with very little physician involvement, we fell to about the 2nd percentile. And our patients loved it, and outcomes were great. There was no decrement in lifestyle. This was around the prostatectomy for an enlarged prostate, not for cancer. So I think the big public policy issue here is that there's been a lot of scare language around the only way we're going to solve our healthcare dollar crisis is around reducing benefits or rationing. And I think one of the things that we want to say is that there's other answers here, and that involving the patient is one of the most important. I think, and another is probably finding a way to pay for that kind of interaction rather than paying for volume. So if you match and you combine that with organization of care, you start getting a picture of how you might resolve our problems without resulting to things that are frightening.
Hi, my name is Lily Keto, and I've been a clinician for about 30 years, and I'm a third-year law student right now. So, but anyhow, there are a number of things I was thinking of, but one thing that I don't think has been quite mentioned thus far is ideology of the regions. One thing I noticed, I'm from a small, rural, relatively conservative area of California, and also that's dominated by a few physicians that do have specific ideas, but I noticed a lot of the communities that either had over or underutilization a lot of them were more of the conservative red counties versus the Bay Area, and it might actually be reflecting the views of the patients. A lot of the patients in some of the more conservative areas prefer to have hysterectomy. Not only are they taking their physician's opinions, but they actually might prefer certain procedures over others. You know, in terms of ideology, that's probably a bad example, but some may. For example, like you see in Berkeley, they have more incidents of the vaginally after having a C-section, whereas I know, just listening anecdotally to some of the people I've grown up with in the smaller areas, they just rather get that stuff out, just do whatever the doctor says. They just prefer to go that route sometimes, and it's not always based on patient communications between the physicians, or maybe it's too much based on communication between the physicians and the patient, but there's also a regional ideology related to utilization of services, I think, that may or may not be taken into account here.
Anybody want to pick up on that?
I don't know, you should have adjusted for voting status.
We could, I mean, I think that's the whole point of what we're doing, right? If that's actually true, if patients in some areas actually have different fundamental preferences for the care that they're getting, and that creates a variation, great. That's the variation that we're after. If, in fact, that's due to something else, and that's because they're not getting good information, so they're being led into that view because they don't understand what's going on, then we want to fix that with more information. But I think that's what we're talking about. So I think you raised the point that I hope we all agree with, or I think we all sort of agree.
I think we do. I think you need to distinguish, though, between initial patient preference and informed patient preference. And many of my patients might come in totally against an intervention, and after information decide, well, maybe I better do this, or I'd prefer to do this. And others would come in initially saying, demanding that they get something, and once they had information, say, well, you know, maybe that's a mistake for me. So I think that it's likely that political ideology might inform the initial more than the informed, in my guess, and I don't have data for that.
I just want to make a quick comment in response to that there were a series of newspaper articles that were done when we released this study, and one of them was done in the Bakersfield Californian, and the reporter there kind of summarized what the study was, but then actually talked to some providers in the community about what they thought about the study. And the reaction of the providers in the community I thought was really interesting, kind of shocking. There was kind of this prevalence of, my patients don't understand their options, so I'm going to make the decision for them. I kind of know what's best for them, which was a little frightening, but I think it might get into that sort of ideology question of, I know better than they do, and so I'll make the decision for them. I'll give them a bypass surgery because they won't take the medication I prescribed for them. They won't follow orders, which was really troubling to me, that kind of the prevalence of that kind of opinion.
Not sure who this question's for. The notion of volume, reimbursing for volume, then what you're going to get is volume. I think that's pretty much, we all can wrap our minds around that. Where I would appreciate the bridge being made is, why would the variation and volume be okay if it's what patients prefer? And I guess the one that leaps out at me from this collection of 13 elective procedures is delivery induction. So I guess, and if somebody could just maybe talk us through that example. So I think the Sacramento community is looking for ways to make sense of a delivery system that today is not rewarding outcomes. But then when I hear, well, maybe a lot of variation would be okay as long as it was informed variation, I think that's a hard, maybe, bridge for a policy crowd to walk over. So hoping you could maybe take us for the journey.
I think there are two levels to your question. And the first level is it okay, should we give patients everything they want? And I think what Lance just talked about, where patients might have come in with one idea and walked out with another when they had an opportunity to share the decision, is really important. In the aggregate, what we're seeing is that patients tend to be less interested in invasive procedures. There is a drop in demand for many things. Oh, I don't know that there's a drop in demand for many things, but for several procedures where there have been studies of usual care versus a patient decision aid, we see a drop in demand. That's important from a policy perspective. It says that we may be delivering more care than informed patients actually want. Now, the question of how much we're willing to pay is another issue. So it's conceivable that what we could do as a nation, as states, as policymakers, is say, once patients have that opportunity to truly be informed and make choices, there may be things that we as a society say we're not willing to pay for, even if you do prefer it. Or we're going to ask you to pay a larger percentage of it, even if you prefer it. So the first step, I think, is to make sure that patients are informed. The second step is to make a social decision about what we're willing to pay for.
I think on the induction thing, the other thing that the years that we studied were 2005 through 9. There's been some attention to elective induction during that time, and I would guess that the numbers might be different for 2010 and 11. And a part of that was because women were made aware of the risk they were taking to their child, and that the convenience that they were getting from scheduling their delivery was not worth it, and that's actually a triumph of informed consent. So there's no doubt that patient demand drives stuff, but with information that it can be modulated.
Great. I see it's 3 o'clock. Is there one last burning question? Or shall we call it a day? Thank you, everybody, for your attention, and thank you, everybody, for traveling from near and far to come and talk to us. Oh, please, evaluations. Please complete the evaluations you've got and pass them. Mary Beth's not going to let you out the door without them. Shoot 'em.